All right, welcome this afternoon. It is a discussion of the blood vessels. What I plan on doing is starting at the heart at the aorta, following the aorta, and then as if we're a blood cell in the aorta, and where we would travel potentially into different vessels in the arms, up the neck, into the brain, maybe down into the abdomen or into the toes. But what I want to do is follow all these arteries just so you get an idea of how they all branch from the aorta and get smaller and smaller until they're eventually blood in the capillaries. So that's the game plan. And then we'll come back by seeing the venous return back to the heart. And when we're done looking at the arteries and the veins, we will explore the lymph vascular side of the circulatory system. So let me share the screen so you see what I'm seeing. And let's show you the aorta. All right. So this is the heart in the center of the chest wall. Okay. The heart is, remember that four-chambered muscular pump, and coming out of the heart is the aorta coming out of the left ventricle, that very big, thick, strong, powerful left ventricle that's designed to pump blood into this aorta with such ejection force that the blood can push into any number of vessels. Now, what I want you to do very first is look at the heart and see right here coming off the aorta where the hand is on the screen is the right coronary artery. And on the other side, somewhat obstructed by the drawing, is the left coronary artery, which comes around and feeds the heart. Those are the first two branches. Let me show you a different aorta where we can see no heart, and now you can see that aortic valve down here at the bottom, and then the first and second branches coming off of that aorta. Here's the right, so we're looking more at the from the side now, kind of, and we're seeing the right coronary artery that's going to go around the heart, the left coronary artery down here, and they'll have their own set of branches. But if blood doesn't go into one of those coronary vessels, which by the way are incredibly small given the size of this aorta, so the amount of ejection volume that you get pushing blood into the aorta, it's pretty intense. So there's a lot of, if you will, slamming of blood into the coronary vessels as they open up from the aorta. And over time, it can contribute to chafing. Okay, it can contribute to chafing and essentially a damaging effect to the inner lining of the wall of those coronary vessels. And it's part of the reason why the coronary arteries are so susceptible to developing what's known as atherosclerosis, because of the repetitive damage to the inner lining of those vessels under such extreme pressure. If they were bigger and wider, they probably wouldn't be so vulnerable to that type of constant bombardment of blood. So I'm pretty convinced that the coronary vessels and these carotid vessels, the reason why we see so much atherosclerotic buildup is because of how close those vessel branches are to the left ventricle under such extreme pressure and power. So if blood doesn't go into a coronary vessel, it'll go up the aorta until it hits this first branch. So let me go back to the previous picture where we can see it come up the aorta, and this very first branch, which is known as the brachiocephalic trunk. And anytime you hear trunk, it's like a tree trunk, which means as you come along the trunk, eventually you're going to have branches from the trunk. So the trunk is basically the base of the branching system of that particular vessel. So this trunk is called brachiocephalic because brachio means arm and cephalic means related to the head. So technically, if we were to translate this artery in English, it would be the arm and head trunk. It should be just known as the right brachiocephalic trunk. There is no such thing as a left one unless there's an anomaly to where there's only two branches, one here and one there, and then we would call that branch, that second branch, the left brachiocephalic trunk. But You'd only know you had that if you were having surgery or something where a surgeon found that vascular variation. If you want to see, I can show you the variations of the branching system of the top of the aorta, but it's really not that important because it's only brachiocephalic for, not even a full inch before it gets to where the clavicle is. And then you're going to have a split in the branching from the trunk. The part that stays to the right and inferior or lower is going to be called the subclavian artery, the right subclavian artery. But the part that continues upward, that's going to be known as the right common carotid artery. And again, whenever you hear common, that just means that you've got a branch that's going to branch to more than one branch with the same name, just different adjectives to describe the branches. So it's the carotid artery, or if you will, a common carotid, until it splits right here in the neck, where the internal one goes up toward the brain and the external one goes out toward the scalp and face. So we'll come to that one. But first I want to follow this brachiocephalic trunk. The brachiocephalic trunk, where it becomes the subclavian artery. All right, so let's see if we can find the subclavian artery right here. But let's do a different view. Here we've got that aortic arch. There are the three branches. Here is the first part, the brachiocephalic trunk of the artery. And then it becomes, if you go upward, the right common carotid, but if you keep going downward toward the arm, then it becomes the right subclavian. Okay, so here against the trunk, there's the right subclavian, there's the right common carotid. Again, look how small the coronary vessels are relative to the branches at the top of the arch. So there's a lot more room for that blood to go into these larger branches under less, if you will, impact. But the amount of impact that the coronary vessels take really is quite intense. All right. So again, coronary arteries here coming off, that's supposed to be the semilunar valve of the aortic opening. And then the arch goes up. There's your trunk. There's your right subclavian. So let's change the search. For instead of looking at the aorta, let's look at the subclavian artery. So I'm just going to put subclavian. I'm not going to designate right or left. So it may show both. In fact, what they show typically is that top of the arch where we can see the subclavian artery start. But what I like to do is find pictures like this where I can actually see the subclavian artery separate from the rest. So here's that split moment where the common carotid goes up, and then the subclavian, which literally runs underneath the clavicle, or if you will, subclavicular, which is how it got its name. And if you notice something, there is a vein going right back up with it. That's the subclavian vein on the right. Okay. So for the most part, where you find an artery, you're going to find a vein. You'll probably even find a nerve, if not a set of nerve. And that's just, and there's what I was talking about, the nerves of the brachial plexus running with that subclavian artery. So there's that the brachiocephalic trunk. Here's the split in the first branching. Again, what goes up toward the head, that is going to become your common carotid. But as it becomes subclavian, we start to see smaller branches like this vertebral artery that's going to go here, like a set of arteries that's going to branch from a small trunk that's going to go to the thyroid gland, and that's going to go to the neck. So it's thyrocervical. This is going to come down toward the breast. So it's the internal mammary gland to come from the inside of the breast, where the ducts of the breast are. And then we've got nerves running next to muscle. There is the subclavian artery. There is the subclavian vein. Notice that they're actually split by a muscle here called the anterior scalene. Okay. The anterior scalene is one of three muscles. There will be a middle scalene on the other side of the subclavian artery. Even the nerves of the brachial plexus with the artery come out in between the middle and anterior scalene, and then they all collectively run under your collarbone, which is called your clavicle, over the very first rib and in toward the arm. All right, so again, some smaller branches, but what we want to see is that subclavian as we follow the subclavian into the arm. Look at that bundle of nerves running with the subclavian And there's a model. As we see the subclavian artery come out, it's going to run down and it's going to enter into the armpit. Now, this is where it changes names again. And it changes names from the subclavian artery to the axillary artery. And if you notice, when we look at the search engine of axillary artery, and this one's on the other side, but it's still the same once it's the subclavian. Let's see the chat. Would you say, in your opinion, that the design of having muscles separating these vessels serves a purpose, as in do they hold cushion to the vessels? That's not a bad question. The answer to the question is muscles probably aren't acting as cushion. More likely, it's in the embryological development of where muscles, bones, arteries, ligaments, or arteries, nerves, veins, once you start to have a certain pathway developing, certain components take that pathway, but it's really the relationship of how things have to travel through spaces in order to share in the general anatomy. And in some cases, that becomes it becomes affected in its development to where an artery is supposed to run parallel to a muscle or underneath the muscle or behind the muscle. Sometimes the artery or the nerve pierces through the muscle, and then the muscle has to grow around it, maybe compromising the blood vessel or the nerve, or the other way around, maybe depriving the muscle of adequate blood supply, so it never really grows and develops properly. I think that there are some muscles that do create the tunnel or the pathway with the skeletal anatomy, but not to ever really act as cushioning. Do arteries typically stay deeper because that depth gives them a greater protection, whereas the veins are typically more superficial because they're not as vital? Yes, that is true. You will see a greater depth to the arteries, but typically not for cushioning or protection of the vessel, because bone does a much better job of protecting blood vessels and nerve than muscles do. And so if you truly needed to protect the nerve, if it was that vital, to protect the artery is that vital, it's going to run basically behind a tunnel of bone. And that's what you're kind of seeing here. If you look at the nature of the subclavian running under the clavicle, it parallels a bit of a hollow of the scapula, then it becomes somewhat exposed, and then it starts running right over the top of the humerus with muscle strapped over the top of it. So it's, if you will, between the bone and the muscle. Can you say that muscles act as, trauma, blocking trauma or absorbing shock or whatever? Sure. It's not really the design of the muscle, but it's one of the benefit of the position of a lot of blood vessels and nerves relative to muscle. So hopefully that answers your question. Yeah. And you really can see the pattern. And if you get a chance to go to the cadaver class, really look for that. Look for the pattern of how arteries and veins run through these pathways, and how you see the body creating natural, if you will, housing and protection for those. It's interesting. I'll do what I can to point that stuff out when we're there. Again, that's Friday, July 19th. All right. So here's the subclavian artery leaving the underside of the clavicle. And as you get into the region of the armpit, the artery is going to change names to become what's known as the axillary artery. All right. So where it says 1, 2, and 3, this is axillary artery. Basically, what you have is the first component of the axillary artery where it essentially starts. Then you have the part that's running right underneath the coracoid process and branching toward the deltoid muscle and toward the pectoralis major muscle. And, because you have to feed your muscles that are in the armpit region as well. And then you have a branch to the third part that's going to spin around to the backside of the shoulder area to feed the back of the scapula. And that's this thoracodorsal and the circumflex arteries. And one of them actually go around the head of the humerus, and that's this humeral one. The other one's going to go around the front, right? So they feed like your deltoid and your biceps brachii. And by the time you get into the arm running parallel with biceps brachii, now the artery changes names to the brachial artery. So notice that it's subclavian just underneath the clavicle, then it becomes axillary in the armpit, And without even changing or branching or anything like that, it becomes the brachial artery all the way down the humerus, and it will then branch once it gets to the elbow. All right. See how the artery has branches that wrap around the shoulder and branches that come into the chest wall. So all those muscles get fed blood. Again, the red part is subclavian. There's no real exact point in the artery where you can say it goes from subclavian to axillary. For the most part, once it's past the clavicle, it's axillary. And then once it's past the scapula, it's brachial. And if you notice right there at the elbow, there's your branching of the brachial artery. And there's some other small branches that reconnect this. And we call those, whenever you have small little branches that come off and then rejoin, we describe that as the vessels anastomosing. And the whole point of the anastomosis, just to give you a trivial fact, is to minimize the loss of blood if one area of a blood vessel gets compromised. It's essentially another roadway, kind of a bypass roadway for blood to take if something is compromising the greater of the vessel. Let's say, for example, that you typically take, I don't know, Highway 64 or Interstate 64 to go to work. But for some reason, there's a traffic jam or they had to close the highway. Well, there's the side streets, that run parallel around where you can go to the next exit and get on past the obstruction. Well, that's kind of what the anastomosing vessels do. They allow potential bypass because, we're moving, we're dynamic. And sometimes there's a greater pressure squeezing on one part of the artery. So we have to rely on another part to get the blood there. Or potentially there's an injury, trauma, infection, any number of things that can limit blood flow in an artery. And so to have these bypassing vessels that anastomose, especially around major joints like the shoulder, like the elbow, like the wrist, we see that, and it's really beneficial. All right, so let's take a look at it now as the brachial artery, and we're going to see the same basic pictures. Brachial artery. All right, so here's the brachial artery as it comes down and then branches at the elbow. There's all those vessels anastomosing around the elbow. Here again, we see the brachial artery running down the arm, running underneath the edge of the biceps brachii with nerve. That nerve is the median nerve. On the other side of it, we'll see the ulnar nerve, right? They run with the artery. The nerves run with the artery. What they're not showing is the vein. The vein will be in there too. This is actually trying to show you how you could press along the edge of the biceps brachii musculatus tendon and feel the pulse, right? Because we saw pulsation in our last lecture, pulse, where you can palpate the artery and count how many times you feel it pulsating in the minute that you're palpating. And that gives you an idea of how many times your heart has beat in that minute, because pulse rate is indicative of heart rate. The pulsations you feel tell you how many times your heart has beat in that minute if you truly palpate for a minute. And this one shows the vein. Shows cutouts of the vein, but it's showing you that pathway between the biceps brachii and the brachialis, where the brachial artery, which is bringing blood toward the fingers, and the brachial vein, which is bringing blood back toward the heart. Different direction of blood flow, but same pathway of blood vessel. Again, at the elbow, we see the split. And when it splits, one big branch is going to go and parallel the radius. The other branch is going to go and parallel the ulna. So let's take a look first at the radial artery, which is the one that most people will palpate for pulse. So let's say you went for a jog, instead of pressing into your carotid, maybe you'll just press into your wrist and feel that radial pulsation and time it. Or maybe your Fitbit or your smartwatch does it for you. So here is the radial artery, and we can see the ulnar artery, right? If it goes toward the thumb, it parallels the bone of the forearm called the radius. So it's called the radial artery. And look what's running behind it, going to the back of the forearm, the radial nerve. I can't tell you how many people told me that the radial nerve was for flexing muscles, when we clearly discussed the radial nerve running to the back of the forearm, where those are the muscles that let go of stuff. Those are the extensors. It's the median nerve here that we see cut that's going to go to the thumb side flexors, and the ulnar nerve that goes to the pinky side flexors. These two are going to the flexor muscles, but that radial nerve, which follows the back edge of the radial artery, goes to the extensors. So if you have not yet taken your test, which is just 2 more people, oh, there's one of them. Make sure that you don't make that mistake. For those that did take the test already, look it over and see if you made one of those mistakes. So again, here's the radial artery. Here is the ulnar artery. And there are branches off of each that make sure that the arm is fully supplied. The radial artery comes down in toward the thumb. The ulnar artery comes down in toward the pinky, and look at that ulnar nerve running with it. Again, the radial nerve is not next to the median nerve. The median nerve is running with the tendons in through the carpal tunnel. But notice the way the radial artery and the ulnar artery both give off what's called a palmar arch, and even a second palmar arch. In fact, even if we follow some of the branches around, we'd see dorsal arches, because the importance of the arches is the arches give off what are called the digital arteries. And those are arteries that'll run into the fingers, allowing the joints of the fingers, the skin of the fingers, everything that needs blood in there. If you, again, put something real tight around your finger, it doesn't take very long for that finger to start throbbing, not getting enough blood. And then as soon as you release the blood, instantly refills all those capillaries that dilated to get more blood to that now deprived area. So there's a great example of looking at the back of the forearm, and we can actually, the front of the forearm, the palm again. And when we see that radial artery come in, it disappears toward the back, and the ulnar artery is what ends up coming more toward the front, because this is the palm. And you can see the way it gives those digital arteries. Okay. All right. So again, here's just the arteries, the radial side to the thumb, the ulnar side to the pinky. We see the palmar arches, we see the deeper palmar arch, and then we see those digital arteries going to the fingers. Ulnar artery, radial artery. And again, that nice arch system, the palmar arch and the dorsal arches that allow the digital arches to develop. Here is the radial artery in green. They highlighted in green. And again, we see it disappearing from the front. This is all the front because it's running to supply the backside muscles. And some of the palm as well. That's a real cadaver. That's what we'll see, something like that on July 19th. Here they're blocking the ulnar artery with the thumb, which it doesn't allow blood flow in here. But notice how the radial artery can use those arches and get blood. So you don't completely deprive it unless you block both arteries. Then none of your fingers get blood. All right, so those are the arteries, radial and ulnar, into the arm. All right. Well, those are the arteries. Now, again, when we do the veins just take us the other direction back out, but we have to account for more veins because there are more veins, especially in the limbs and in the abdomen, than there are arteries. In some places like the brain or in the heart itself, where you don't have much space to allow for more veins, you'll see a 1-for-1 ratio, but then the veins use some type of sinus, whether it's created by the dura mater or created in the channeling of the heart muscle. This allows the veins a large avenue of draining the blood back to the vena cava. And I'll show you what I mean when we get to our veins. All right, so we need to go back to that carotid moment and look at, and I'm going to do the right common carotid. Oops. Right common carotid. There it is. So again, we're in this moment where the brachiocephalic trunk goes upward. And when you look at it from here, we can see how large that common carotid is going up into the neck. And then as it gets almost to the mandible, not quite, but almost to the mandible, there's going to be a split in the common carotid. One part is going to go superficial and toward the face and scalp, and that's what we call the external carotid artery. But the other part goes deep into the neck, and that's what's known as the internal carotid artery. The external and internal carotid. Now, let me explain why the carotid artery is called the carotid artery. Carotid, as a word, means drowsy. Drowsy. And people recognize that whenever you pressed against the artery, it would make a person feel lightheaded or drowsy. So it was known as the artery of drowsiness. And so instead of calling it the cervical artery, anatomists just stuck with that drowsy word, carotid. All right. So the nice thing is that even if you've never taken an anatomy class, you've probably heard someone describe the carotid artery, right? Because in movies and TV shows, that's often where the doctors take pulse, or the forensic pathologist, or the murder investigator, the police officers, whoever arrive on scene of a crime where there's a homicide. Well, they always press into that carotid artery to see if the person's alive, still breathing, or whatever. So, most people don't just carry a stethoscope and stick the stethoscope on the heart. It's easier just to palpate that big carotid, which is superficial in the neck, relatively speaking, and feel for a pulse. And if you don't feel for a pulse, there's a good indication that the heart's not beating, right? Because of the homicide or the death, if you will. So again, here is that right common carotid. Notice that the left common carotid doesn't share a branch with the left subclavian. And by the way, the left subclavian is just a mirror image of the right subclavian once you get to where it's subclavian. In fact, once you get to where you're just common carotid and away from the subclavian on the right common carotid is not much different than the left common carotid. They're basically the same thing on opposite sides of the throat. And again, just before you get to the mandible, a little bit below the mandible, it's going to split. The external carotid stays to the face and scalp. The internal carotid will eventually go to the underside of the brain, through the brainstem, and into a branching pattern all around the brain on all of its parts. So this is more of a three-dimensional illustration of that common carotid. And by the way, you can see the branch of the subclavian where the vertebral artery runs up in through the side of the neck and eventually joins back up with the internal carotid deep along the brainstem. But the external carotid feeds the face. It feeds the teeth, it feeds the tongue, it feeds the muscles of chewing, the muscles of facial expression. It's good blood supply for your face and scalp. Okay? Your face and scalp, the blood supply comes from the external carotid artery. But it's the internal part with this vertebral artery, just those two on each side, this internal part in that vertebral artery, that are really bringing blood to your brain. So you would think that we'd have a lot bigger blood vessel bringing blood to the brain. But the carotid, internal carotid, and the smaller vertebral artery, they're basically the two on each side. So 4 total blood vessels bringing blood to a brain that deprives you of 20% of your oxygen. And there's the split, where common becomes internal and external. So if you follow the internal here, notice how the internal is going to come up to the underside of the brain and then over toward the brainstem, and then right along the underside of the brain where the pituitary stalk is pushing down toward this thing called the pituitary gland. The vertebral artery, which came off of the subclavian, it's going to run along the vertebrae until it leaves over the top of C1, and then it comes up and it joins up with its counterpart, the other side, along the underside of the brainstem at the part of the brainstem called the pons. And there's a cleavage in the pons where the two vertebral arteries come together, and that forms what's called the basilar artery, which is right here. Then there's a whole circle of arteries around the stalk of the pituitary gland, and that is referred to as, you can see it here, the circle of Willis. The circle of Willis is important because it is the most common place to find aneurysms of the arteries that often lead to strokes. One of the pathologies that we'll see tomorrow is aneurysm. An aneurysm, see how nice and clean these arteries are? They're nice and tubular. There's no ballooning, no bulging. Well, an aneurysm is a ballooning or a bulging of an arterial wall. And it happens so commonly around this circulation of, this anastomosis of sort of circling artery around the pituitary stalk, that if that bursts, then an entire part of the cerebrum, for example, will be deprived of blood. And that's a hemorrhagic stroke because of an aneurysm that ruptured. So it's a very scary thing. So cardiovascular surgeons, especially neurovascular surgeons, they get to know the pattern of blood vessel in the circle of Willis extremely well. So again, here's that carotid, and there's the internal going toward the brain. Here's that vertebral artery running along the vertebrae and then becoming basilar and joining up at the circle at the brain. And then all of the branching pattern that supplies the brain comes from those two arteries contributing blood to the whole of the brain. And then again, the external carotids, they bring blood to the entire scalp. I don't care if it's the back, top, front, face, jaw, teeth, tongue. It's that external carotid. A few smaller branches too, some other little branches off the subclavian will feed the underside of the tongue and face, but most of it's external carotid. External carotid going to the face and scalp. Again, we can see the vertebral arteries coming up and in, and there's where it becomes basilar with these little tiny perforations to feed the brainstem, and then there's your circle. That's the circle around the pituitary stalk. And again, it's such an important area for aneurysms. I'm actually surprised when I do this, I'm not seeing pictures where it's showing us aneurysms of that part of the artery. Again, this is why it's called vertebral artery. It runs through holes in the vertebrae. If that's not an example, Ina, of the body creating a tunnel system, then nothing really is. That artery doesn't really have to go through the vertebrae. It could be adjacent to them, but you get somewhat of a pathway where that artery can be, if you will, kind of protected, but at the same time, if you were to injure the vertebrae, you can injure the artery as well. And one of the common things that happens with this thing called the vertebral artery is what is basically a type of internal version of an aneurysm known as an arterial dissection, where the wall of the artery tears. And unfortunately, in my profession as a chiropractor, because there have been incidences where there have been chiropractic adjustments that may or may not have directly related to that dissection of the artery, a lot of times when somebody has this type of dissecting of that vertebral artery, the first question that they ask you in the emergency room is, have you been to a chiropractor in the last 2 or 3 days? And if the person has, they immediately say, oh, that's the cause of this dissection. But there are people that have never one day. I actually have a patient right now whose son is his girlfriend. They're in their 30s. His girlfriend, who I think she said was 32 or 33, she had a type of stroke. And when the vascular surgeons started doing testing, they found that she had a dissection of her vertebral artery. And the very first question the surgeon or the emergency room doctor, whoever was, found out is, have you been to a chiropractor? And she'd never in a day in her life been to a chiropractor or had her neck adjusted. So the question is, well, what caused it? And I'll tell you, it's the same thing that causes most of them, whether a person's gone to a chiropractor or not: a fall. A fall where your head and neck get torqued a little bit. And it puts a type of stretch against the neck that causes that dissection. And so a lot of people, after they hurt their neck like that, they have trouble turning their head, so then they seek out a chiropractor. And chiropractors are supposed to be trained well enough to say, hey, there was a potential for an injury to this artery. We need to do a workup to make sure that there's not an injury to this artery. But some chiropractors are quick to go, oh, if we adjust it, you'll be fine. And so they're missing the fact that there was an injury to the fall, plus now the adjustment, which most likely doesn't have anything at all to do with the dissection, but it's real easy to lay blame. Does that make sense? So it's the downside of again, my profession, but it can happen with massage therapy as well. Some people after a fall like that, they'll have soreness or they'll have muscle spasms as a result of injury to their neck. And then they seek out massage therapy. And some massage therapists get in and do some deep tissue work or stretching or whatever. And then the person ends up again having a stroke. And now you've got the doctors going, well, it's probably from the massage therapist, right? Completely discrediting that it could have been from the original injury from the fall. Because the surgeons or the emergency room's approach is, well, if it was dissected, then within a few minutes or a few hours of that injury, they would have been in the ER. And that's not necessarily the case. You can have an underlying injury where the artery is not quite dissected or injured. I mean, there's an injury there, but remember, it's pulsating, it's under pressure. And that's what eventually, especially with the inflammation that ensues because of the fall, eventually leads to the potential for the dissection. So just be really cautious. If your clients have had an injury to their neck or a fall, car accident, whiplash, something like that, just be diligent in how you assess, determine the level of swelling or muscle spasm, and only do your massage techniques to a certain level of tolerance until they've had an opportunity to heal with time. And they should always, following a car accident like that or a fall like that, have some medical attention first, or potentially within the same time frame, so that the urgent care doctors, surgeons, ER doctors, that they could potentially rule out that there's damage to this vertebral artery. All right, so that's my pedestal, if you will, of discussions with this particular artery. But it is part of the reason why the medical world will tell patients, don't ever let chiropractors adjust your neck. And I think that's a poor bit of advice based upon, well, misinformation. All right, so that is the carotid. Let's go ahead and follow the carotid to where it becomes cerebral arteries, the branches off of the circle of Willis, the cerebral arteries. And I actually love the pattern of cerebral arteries. I just intrigued by how those arteries branch and run through the sulci and over gyri. Here is that basilar moment, right, where the vertebral arteries come together, and then you've got the carotid, internal carotid coming in toward the top of the circle. And once that comes in with the circle, then it starts branching again, and now we've got branches all over the cerebrum. So, you know, either as the branches get smaller, they start having their little individual names. But a lot of the naming of the arteries around the cerebrum are relative to the parts of that, or even parts of the brain. Like, for example, here you've got the corpus callosum, right? And as the artery comes around, we see it coming toward the front. So it's referred to as the anterior cerebral artery because it's going to supply the front lobes, the anterior lobes, as coming in. And then again, they become smaller and then start to become more variable from person to person. But if it stays to the posterior aspect, it'll be a cerebellar artery, or maybe it'll be a posterior cerebral artery, all right, or the superior cerebral branching of the artery. So it's, again, something that surgeons and neurosurgeons especially are very well versed in the branching pattern of these. You can see the way the cerebral artery comes in. It has small little branches to the underside of the basal ganglia, how the artery will crevice into the sulci. It'll run along the sulci. It'll go over the top of gyri. This is that stalk I was talking about, the pituitary stalk. That's the pituitary gland. And again, the circle is around the stalk. Oh, that's a nice circle right there. You can see the circle. But again, a nice little pattern. And then based upon the lobe, the artery is named for the lobe of the cerebrum. So here we have parietal branches. There we'll have frontal branches, occipital branches. So that's how the pattern of artery works. And eventually it'll get into the small capillaries where the astrocytes and the ependymocytes are able to just branch right in and take the blood. Here's the circle. Take the blood, feed the neurons, feed the neuroglia, and keep the brain healthy and happy, full of oxygen-rich blood. So again, when there's such a variable blood pattern of vessel, any one of these vessels can rupture, any one of these vessels can get blocked. And if that happens, a certain amount of brain becomes really damaged. And so let's say that the circle of Willis right here, where the left cerebral artery is going to branch off. And let's say that it bursts right here. Look at how much brain is going to lose blood just from it hemorrhaging right here. What happens oftentimes is that you'll end up with an aneurysm, what's called a saccular or a baryaneurysm right here. And when that bursts, this whole area of the brain, related to personality, mood, speech, that person loses that. So they may seem like there's no real thrive or thrill anymore, or their personality has done a complete 180 to what it was prior to the stroke. That yellow thing's the circle of Willis. And you can see those cerebral arteries branching off. So just a really nice, rich pattern of artery to the brain. All right. So now, since we've seen blood vessels go up toward the brain, let's watch blood vessels leave the aortic arch and go down in through the thoracic wall and into the abdomen. So for that, I'm going to go back to the aorta, but I'm going to put abdominal aorta. Abdominal artery, I meant to do aorta. Aortic artery anatomy, there we go. All right. So this is a good example of following the abdominal aorta and seeing just branches to various places, right? So this is looking at the artery without any of the vertebral column the way on the left side of the page. And we see a branch that's going toward the spleen, right? We see branches that are going around the stomach. We see branches going to the liver, into the pancreas. But we also see branches that are coming off and going to the adrenal glands, toward the gonadal stuff of the ovaries, toward the intestines. That's what mesenteric arteries are. They're intestinal arteries. Gastric arteries are stomach related. Splenic arteries are spleen related. Omentum is a superficial blanket over the intestines. So artery to the omentum, different parts of the small intestine, the pancreas. It's really quite inundating as far as the amount of vasculature that's in the abdomen. And it's the reason why there's so much potential for internal bleeding with trauma, especially motor vehicle trauma, because there's so many small branches of arteries, whether it's inside the organ or in the abdomen itself, that could potentially be lacerated, injured, and have that bleed to where, it's not going into the capillaries feeding the tissue of the organs. So lots of little branches coming off the aorta. Does that make sense how I'm presenting it? Lots of little branches. But notice that these particular branches are going toward the kidneys, toward the stomach, toward the spleen, right? And by the way, don't mistake these arteries right here. Those are arteries that are coming out of the right side of the heart to go into the lungs. But they better not be drawn red if it's an illustration. They better be drawn blue. The arteries of the lungs are drawn blue because of oxygen poor blood. By the way, here's a healthy looking aorta. Here's an abdominal aortic aneurysm, a AAA, abdominal aortic aneurysm. I mean, that looks like, I don't know, a nice healthy tube. That looks like a swollen ballooning tube. And that can eventually get so ballooned that it thins out and it bursts or ruptures. And if that happens, the amount of blood loss is not really conducive to life. Notice that we've got that abdominal aorta coming down, and we see the superior or the inferior vena cava going up. They are parallel to each other. We'll see that on the end, if you will, as we're coming back, bringing blood back to the heart. So, yes, there are a lot of branches, but what I want to show you next are branches that are being cut away. So here we've got what is called superior mesenteric and inferior mesenteric arteries. Anything enteric relates to the intestines. The mesentery is the tissue that lines or follows the tubing of the intestine. And it's mostly adipose with blood vessel in it. So let me show you these mesenteric arteries because they're really just arcade after arcade of artery arching and cascading and then arching again. And it's a very rich network of blood. So mesenteric artery anatomy. Here we go. All right. So I'm going to show you this picture first, where we see the mesenteric artery coming and then branching, and look at the arching, and then the next arching, the next arching. This tissue between the intestines is called the mesentery. And because the vessels branch through the mesentery to get to the intestines, they're called mesenteric branches of the superior and inferior mesenteric arteries. So again, this is just if you will, a single example, but it looks nothing like that. That's schematic, if you will. That is much more realistic of what the arteries to the intestines look like. Down at the bottom of the picture, you see what are called the small intestines with the mesenteric branching. And then to the top of the picture, those are the large intestines, also known as the colon, with the colonic arteries coming off of, or sorry, the colic arteries, not colonic, colic arteries that are coming off and supplying each of the divisions of the large intestine. Again, look at the branching, look at the arcades of continuous connection and branching. So here we've got this green division to the yellow division to the small intestines, and then more yellow to the large intestine, and then the very end, and that's the rectum. It's supposed to be the squiggle of the sigmoid into the rectum. I already saw that one. I saw that one. There. So what they did was they pulled the small intestines out. You see all the artery running, and then that's the end of the small intestine. Look, a branch from that to that's called the appendix right there. It looks like a worm, so it's called the vermiform appendix. This is the very beginning of the large intestine called the ascending colon. It'll eventually go up, turn 90 degrees, go across, turn 90 degrees, go down, squiggle back toward the vertebral column, turn 90 degrees, and then you've got your rectum where feces will accumulate until you're ready to void. So lots of arteries in the abdomen, if you will. That's one of my all-time favorite pictures because you can see over 20 feet of small intestines and all that blood supply, and then another roughly 3 feet of large intestine. And those are lymph. That's lymph. Lymph nodes, lymph nodes, lymph nodes. All right. So now we get to the very end of this artery run of the aorta, right here at the bottom. And that is where the aorta splits. And it is somewhat level to your pelvis, what we call the crest of the ilium, the iliac crest. Let's see if I can find one with a vertebral column showing the split. Because there's a nice split. There's a nice split. There's a nice split. None of it so far is showing up there. There's your pelvis. So if you come to the level of the iliac crest, notice that that's roughly where we're seeing the split of the aorta. And this initial branch on each side is called the common iliac artery. Why common? Because it's going to split into two other iliac arteries, but this is before they split into their two respective iliac arteries. When they do, the internal one is going to go in toward the center of the base, if you will, the base and into the bowl of the pelvis. And that's where you feed the uterus, the urinary bladder, more of feeding the ovaries with some of these other branches that have come down from the abdominal aorta. So it goes in toward the groin, but the external one is going to run over the pubic bone. So let's find that. So let's type in common iliac artery. You see here, that's the uterus, that's the ovary. So here, that's what I'm looking for. So here's where it's called the external iliac. And it goes over the pubic bone underneath this ligament called the inguinal ligament. And once it's past that pubic bone and inguinal ligament, it changes names from the external iliac artery to the femoral artery. The femoral artery. There it is on this imaging as common. Then it's going to become external here. It kind of blacks out, but we see it coming in the pelvic bowl. And again, as soon as it leaves the pelvis, as soon as it crosses, there it is, crossing past the inguinal ligament. See, they schematic line the inguinal ligament. Now it's called the femoral artery. Common iliac, internal iliac, external iliac. None of this is ever going to come back to haunt you, really. Because if it's the aorta, it splits at the ilium to the iliac arteries, and then again changes names to the femoral artery once in the thigh. So let's take a look at that femoral artery. Femoral, F-E-M-O-R-A-L. Some people say it's femoral. Sometimes I do. Sometimes I say femoral. Sometimes I say femoral. Same thing, people. Here it is with the nerve and the vein, all three running underneath that inguinal ligament. The artery is, again, a little bit deeper than the vein, but they're both pretty deep. Unfortunately, they're not deep enough, making them extremely superficial right here. And my explanation to why that is simple. If you look at a four-legged animal, their thigh is almost 90 degrees to the pelvis. And so you get that 90-degree change, and you get the protection of the position of their body on four legs. But as the body comes upright, it exposes that area of the groin, the inguinal region. So what should be deep actually becomes somewhat superficial. And so it's not really protected by the anatomy anymore. So many bowsmen, spearsmen, archers and swordsmen from back in medieval times, this was a target point to strike an enemy, because it would sever the artery, and that enemy would bleed out. Within just a few seconds, you'll be unconscious. In a few minutes, you're dead. So that's your triad of femoral artery running with femoral nerve and femoral vein. Look at that femoral nerve getting ready to branch to all those muscles of the quadriceps in the front of the thigh. And again, we can see the artery coming down. The greater part is a little bit more superficial than the deep one. The deep one's going to end up running along the bone edge and wrapping around. The deep one runs with the adductor magnus, goes behind the knee. And what's going to happen behind the knee will be another split in the artery. The femoral artery will split behind the knee. So let's look at the posterior, which means the backside, tibial artery. Because if we look at the back, we can see that femoral artery now running with what will become the tibial nerve, right? And by the way, the artery will change names in the back of the knee. Popliteal, split, and what stays along the inside with the tibial nerve is called the posterior tibial artery. What runs lateral to the outside leg becomes the fibular or The peroneal artery. All right. The peroneal artery stays along the back edge of the fibula. The tibial artery that's in back is called the posterior tibial artery. It will end up underneath the foot. Essentially, the posterior tibial artery going to the underside of the foot, it's not much different than the ulnar artery of the forearm. Okay. I mean, as far as how it runs. And you could argue that the fibular artery, also called the peroneal artery, is kind of like the radial artery. It stays a little bit more superficial, but they'll still both become arches, just like we saw in the wrist. These are now called dorsal and plantar arches of the foot. But what we don't see is this right here. You see this branch at the top coming off of this popliteal artery? That branch is going to run through a hole between the tibia and the fibula in the interosseous membrane. And it's going to end up running down the front side of the tibia as the anterior tibial artery. So there's actually a front side tibial artery called the anterior tibial artery and a backside tibial artery called the posterior tibial artery. All right. So there are two tibial arteries. Again, here's your backside one, the fibular or peroneal one running to the outside. The backside one runs with the tibial nerve. Here is the anterior side of the leg. That is the anterior tibial artery running with the deep peroneal nerve. This is the posterior tibial artery running with the tibial nerve. If we wanted to look at the anterior, this is your anterior tibial artery. The one that goes through that hole in the interosseous membrane and then runs down the front of the leg to the dorsal arches. Right? Whereas the posterior tibial artery stays in the back, runs down the back of the leg, and it goes to the plantar arches with some branches contributing to the dorsal arch. So the green one there is anterior tibial. Look in the background, see the little posterior tibial. Here is it's called the tibialis anterior muscle. The artery runs underneath it with the deep fibular nerve all the way to the top of the foot. So here's the whole of the system from the aorta at the top to the common iliac artery to the external iliac artery to the femoral artery. Down the back is the posterior tibial artery, down the front is the anterior tibial artery, or branching off of the posterior tibial artery and going to the fibula, the peroneal or fibular artery, but they eventually all come to form their dorsal and plantar arches, which give off the digital arteries feeding the toes. And those are the arteries of the body, and that's how they work. That's a great picture right there of the tibialis anterior after it's been removed, to see that deep running anterior tibial artery down along the right, because the muscle's been somewhat removed, so we don't see all of it. And then we see it running with the tendon of tibialis anterior. We can see the nerve branch of that deep peroneal nerve running right underneath it. And there's the superficial peroneal or fibular nerve running along the outside of the leg. So we have one picture that's showing us the anterior tibial artery and one picture showing us the posterior tibial artery. And there would be your fibular branch right there. That's going to go along the fibula and become that fibular or peroneal artery. All right. So this picture has arteries and veins. And this is what I want to do. I want to follow the veins now back up the leg. And look, all I have to do is change this to vein. And guess what's running up the front side of the leg with the anterior tibial artery, but it's bringing blood back to the heart. The artery is the white thing. The vein must be the blue thing, right? The vein. There's the anterior tibial vein. Anterior, the peroneal vein or fibular vein, the anterior tibial vein, the posterior tibial vein. So everywhere where there's an artery, we now have a vein, but bringing blood. Why does it show me all that artery? I want vein. Oh, because I guess I didn't do a good job of separating it. All right. So the posterior tibial vein, oh, look, it's not one, it's two. The anterior tibial, oh, look, it's more than one, because there are twice as many veins in the arms and legs as there are arteries. A great view of the anterior tibial vein, the posterior tibial vein, and eventually they become the femoral vein. Here we've got the posterior tibial vein, the anterior tibial vein from the front meeting up with this fibular vein. They all collect behind the knee, run through the popliteal component of the back of the knee, and then the vein changes names to the femoral vein. And eventually, this purple thing, which is another vein in the leg going all the way up the inner leg. Well, actually, that should be on the other side. That's just from the deep side. There's going to be one more vein along the inside of the leg, all the way up to the groin. And that is an extra avenue of blood back out of the leg. So look here. Here we've got the posterior tibial veins, the anterior tibial veins, veins from the soleus muscle, gastrocnemius muscle, the big femoral vein, and then it's going to dump back up into the external iliac. But we have to account for one other vein that runs the entire leg and thigh, and it is the vein of all veins, according to the Greeks, and it is referred to as the great saphenous vein. First thing to understand about the great saphenous vein is this. Look at the picture. It's not deep to muscles like we saw with the posterior tibial vein or the femoral vein. No, this thing is superficial. It is a vein outside of the fascia of muscle. It starts here in the foot, in front of the ankle. It goes all the way up the inner leg, all the way around the knee, all the way up into the groin, and then it finally dumps into the femoral vein way up at the top near the groin. This is an added bonus vein to get all of this skin and superficial musculature drained of blood being returned back to the heart. Look, we only had really a big femoral vein with a few branches, like the deep femoral vein, posterior tibial vein and some branch, or excuse me, femoral artery with its branches, tibial arteries with their branches, right? But you have the same veins as you do the arteries, plus this extra. In fact, you have two veins for every one of those arteries going out. So it's twice as many veins as there are arteries. Here you've got that fibular vein coming back up. Here you've got the anterior tibial vein going back up. And here you have the great saphenous vein going all the way back up. This is bringing blood back toward the heart. And when that blood gets to the femoral vein dumps in the external iliac vein. The external iliac vein meets with the internal iliac vein, and they both dump into the inferior vena cava. The great saphenous vein. Now, please remember, blood is not coming from this vein to the body. Blood from the body is going through this vein and back toward the heart. Back to the heart. There is a small saphenous vein, but there's also a great saphenous vein. Extra veins. Here are variations of the venous return. But again, eventually, the great saphenous gives way to the femoral vein. And when we look in the thigh, we see superficial branches, we see deep components. There's your femoral vein. There's the saphenous coming into it. Great saphenous coming in the femoral vein. And once we are at the, I'll just put iliac veins, and it'll show us the way the external and the internal become the common iliac vein, and eventually all that blood goes into the inferior vena cava. Now, I want to show you those mesenteric veins, and it looks just like the arteries. However, there's one big difference. Okay. Here's a picture of the intestines, both small and large. There's the pancreas, there's the stomach. I want you to notice where every vein is going, whether it's from the stomach, whether it's from the small intestines, the large intestines, they all go to a vein that goes to the liver. It's called the portal vein, hepatic portal vein, liver portal vein. All of this venous return of blood spent by the cells of the stomach and the intestines. And here's the thing, in the stomach, in the intestines, you have absorbed material into your blood. And that material came from your food. It is foreign agents. So we want all of this newly enriched blood from our intestine, stomach, etc., to make sure it gets processed by Ellis Island in the liver, where the Ellis Island of the liver can say, okay, user friendly, you're good for the country, and then let's go back into the venous return to the heart. But the liver's job is to make sure that all of those newly acquired ingredients are user friendly. So whether it's the spleen, the pancreas, the large intestine, the small intestine, the stomach, they'll all have venous return channeling through the liver before the liver brings that blood back to the vena cava. It's called the hepatic portal system. And again, it's to make sure that all this blood of potentially newly acquired food of our abdominal organs gets into the liver for detoxification. Again, here we have all those veins paralleling the arteries in the mesentery. But when the veins go, they don't go right back over to the vena cava. They bypass, or if you will, they go to a portal, a doorway of the liver. The blood then disseminates throughout the liver while still in veins, goes through small capillaries. So you actually have your pre-venous or your pre-capillary veins and then your post-capillary veins, and then back out through those veins. So there's roughly 4 times as many veins in your abdomen, given all those liver veins, relative to the arteries. Roughly 4 to 1. The arms and legs are only roughly 2 to 1. All right. So let's take a look at the inferior vena cava, because that'll bring blood from all these organs back to the heart. Inferior vena cava. Hello. Inferior vena cava. And again, vena is another Latin way of saying vein. Greek is phlebe or saphina. Cava. So we can see all the way from the bottom, level to the iliac crest, where those veins are coming together at the IVC, the inferior vena cava. And whether it's the kidneys bringing blood back to the inferior vena cava, whether it's the adrenal gland bringing blood back to the vena cava, right? Those are directly into the vena cava. But all the other organs of the abdomen that are digestive in nature, their veins go to the liver, and then the liver returns the blood to the vena cava. And that would be, again, the hepatic portal system and the hepatic veins taking the blood back to the vena cava. Notice that I did not show you arteries coming out of the aorta that parallel the ribs, but they do, right? They sit right on the bottom edge of the rib for protection. And then the vein also along the rib for protection brings the blood back into the vena cava, and to the heart it goes. And there is the superior vena cava, but that's where we want to end on the other side. All right. So let's go and look at the brain and follow blood down from the brain. And so what I'm going to do is cerebral vein anatomy. And again, we see veins on the cerebrum, right? See these veins? But notice it looks a lot like the arteries. It's not twice as many or 4 times as many. You know why? because of these massive things right here called sinuses. They're called dural sinuses. There are arteries and veins in the brain, but the veins of the brain always drain the blood toward one of these, either sagittal sinus or squamosal sinus or straight sinus, or any one of these. These are created by the dura mater. You remember the dura mater from the nervous system? It's 2-ply. And along certain places, the 2-ply splits and forms a channel or a ditch called a sinus. And all of the veins of the brain dump blood into the sinus so that the sinus acts as a channel, or if you will, a big ditch for getting the blood out of the brain without having to have 2 to 3 times as many veins to get blood back to the brain. So the arteries and the veins look very similar, except for the veins have those sinuses to use, dural sinuses. Here's the big sagittal sinus, straight sinus into the sigmoidal sinus. Here is the inferior sagittal sinus. The sagittal sinus is the big one. It's just a massive amount of, if you will, collection of cerebral spinal fluid and used blood by the brain. So that's arteries and veins. And then we see the big channels called sinuses to get blood out. So really, everybody, blood's not rushing to your brain when you're upside down. Blood's rushing to your brain right now because your heart's making that happen. But when you're upside down, since the dural sinuses don't have valves, they get congested. It takes longer for blood to get out of the sinuses, so you feel the congestion of greater volume of blood that hasn't left your brain. Those are the sinuses that the veins use. And just to let you know, the heart has its sinus also around the outer edge, and it acts in the same fashion to allow coronary veins to use that central sinus to get blood back into the right atrium. All right, so those are the cerebral veins and arteries, and the veins using the sinuses. Now, when the sinuses come to an end, they dump their blood into what's called the jugular veins. The brain uses what's called the internal jugular, and the face and scalp use the external jugular. So I'm going to show you the jugular veins, which is really an internal and an external set. Here are the veins. We see the veins of the face and scalp coming into the external jugular. We see the blood of the brain and its sinuses coming out into the internal jugular. Here are the sinuses, right and left one. Here we have the very end of the dural folds, and now we have the internal jugular veins. Here's where the external jugular comes and joins behind it, but it's not until the jugular veins get to subclavian that their blood is returned toward the top of the heart. This purple thing is supposed to represent the lymphatics dumping into the vena cava as well, through the subclavian vein. So there's your internal carotid, the big thick one to the inside. Here's your external carotid, the smaller one to the outside. Again, blood in those carotids, the carotids going to the brain, blood in the jugulars going from the brain. So oxygen rich to deliver blood to the brain, oxygen poor because the blood's been used by the jugulars to get back toward the heart. Look, there were not only vertebral arteries, there are 2 vertebral veins. Here's your internal jugular, and the green is your external jugular. So jugular is parallel to carotid. Again, blood's going toward the heart, whereas carotid's blood's going away from the heart. So here's both together. Carotid bringing blood up to the brain, internal carotid, internal jugular bringing blood back toward the subclavian vein. All right, let's go into our fingertips, and let's look at the radial vein coming out of the hand. And it'll look just like the artery. There's the radial artery, there's radial vein, there's the ulnar artery. We should see the ulnar vein, but not in this picture. Okay, so there's the ulnar artery. Where's the ulnar vein? Come on. I'll just show you. Ulnar vein. I'll just go with this picture. Okay. So, all right. Let me explain what you're looking at here. In fact, I'm going to open this picture as its own image. Okay. So down at the bottom, notice how many veins you see here. And what you can't tell is what's deeper and what's superficial just by the drawing. So what you have to do is look, if it's the darker blue, the more royal blue, not the grayish blue, it's deep. So the radial vein is deep on the backside of the radius, or really the outside of the radius. The ulnar vein is deep along the inside of the ulna, and they come together, radial and ulnar, to form the brachial vein, which is the middle and deep of the three. So what I want to have you do is look at your own arms, and I want you to find some veins. And what you should see is maybe a little bit of vein along the inside of the forearm here, but you should also see a vein right over the top of the biceps. That's what this is trying to show you. The one that's along the inside, all the way from the pinky, is to the arm and forearm and arm, what the great saphenous vein was to the leg. It starts down at the wrist and pinky finger. It goes all the way up the inner forearm and into the arm, right along the edge here, underneath the edge of the biceps brachii. Okay, and eventually into the brachial vein. So again, we've got ulnar artery and ulnar vein and radial vein running with the ulnar and radial arteries, but then those two veins come together to form the brachial vein, which is running with the brachial artery. But those are deep. The superficial side has what's called the cephalic artery going all the way up the thumb side and then over biceps brachii, and then the basilic artery running along the pinky side of the forearm all the way up the inside of the arm. So again, it's not really three veins in a line. It's, if I remove the skin, we would see that vein. If you look over your biceps muscle, you see this vein, but you do not see the brachial vein. It's underneath the biceps brachii. It's deep with the brachial artery. So this picture is trying to show you superficial veins and deep veins at the same time, and it makes it look busy, but it's really quite simple. If the vein is running along the ulna, we're going to call it the ulnar vein, assuming it's deep. If it's running along the radius, it's called the radial vein, assuming it's deep. If we see the vein running all the way up the inside and over the top of biceps, or if we see it running all the way up the inside, or if we will, just in labeling purposes, if you see three veins, the middle of the three is brachial, the outer of the three is going over the biceps, which is why it's cephalic, and the inner, if you want to just think the base of your arm, has the basilic vein. Look, I know the word basilica is the same as the word basilica that you hear in churches. I just don't know what it means. It's something pretty standard. I just don't remember what it means. But if you need to see it as basic, then see it as basic, or as baseline. See this as the inner vein as the baseline vein. But it's really quite superficial. I mean, you can see it on some people right here. Whereas the cephalic, especially if someone works out, it goes right over the biceps. You looked up basilic, let's see what it means. Recorded from the mid-16th century, the word comes from Latin, literally means royal place. Okay, royal. Basilica. So it's where the king and queen pray. So I don't know why they call this the royal vein. Probably because, like great saphenous, it's this great vein running the entire extremity. Here we've got this great vein, this royal vein running the entire extremity. All right. Cephalic is really, especially with workouts, people will come in and you'll just see that vein right on top of the biceps brachii. So in a real situation, cephalic is easy, but when you're looking at a two-dimensional illustration like on the screen, well, what they did was they darkened the vein. It's like a gray blue for cephalic and basilic, but a dark blue. But again, if you look at my fingers, I've got 3 fingers in front of 3 fingers. The deep one, radial and ulnar, become the deep brachial, but cephalic and basilic, they're just going to stay superficial the whole way up. And again, they will eventually become the subclavian vein. The subclavian vein. And once they're subclavian vein, they're running with the subclavian arteries. And this is where a lot of happening happens, if you will. A lot subclavian. A lot of coming together at the subclavians. Oh, that's artery. I want vein. So again, there's that subclavian moment, right? Where all those veins are coming together to form the subclavian, and then it runs under the clavicle. It joins up with the internal, and then there'll be an external jugular also. Even the lymphatics are dumping into the subclavians, and then the subclavian comes down and becomes the superior vena cava. Here is the right subclavian becoming the superior vena cava. Here's the left subclavian becoming the vena cava. But look, internal jugular is coming in right there. External jugular is coming in right there. Here's the thoracic duct coming in right there. Here's the right lymphatic duct coming in there. It's a very busy area where the subclavian is getting ready to become the superior vena cava. That is just the vein subclavian before it becomes vena cava. Here we've got subclavian. There we've got vena cava. So it always is bringing blood. There's lymphatic. That's called the thoracic duct of lymphatic, putting lymph back into the subclavian. This is thoracic duct, so that's the left subclavian. If it was the right lymphatic duct, it would be the right subclavian. Here's the carotid. Here is the subclavian artery. Again, that would be jugular, internal jugular, and subclavian. So blood flow's going this way with the veins. Blood flow's going that way with the arteries. Subclavian arteries, blood out. Subclavian veins back in. There you go. Right subclavian, left subclavian into superior vena cava. Here we have a hemiazygous and an azygous vein. Those just run parallel to the vertebral column. We'll actually see the thoracic duct running right in between them. And the thoracic duct looks about the same size as the hemiazygous, which is considered a small to medium vein. And that's the largest lymphatic. It's this green thing right there. That green thing is the same basic size as the vein it runs parallel to. Again, remember I said the deeper brachial vein, the more superficial basilic and cephalic, but they all come together and form the subclavian. There's your azygous and hemiazygous. Those will never come back to haunt you. It's just when we talk lymphatics, we're going to see a thoracic vessel called the thoracic duct running in between them. That green thing is the thoracic duct. That's the largest of all lymph vessels. Look, the vena cava, especially the inferior vena cava, is the largest of all veins. Look at the size of the vena cava compared to the size of the largest lymphatic vessel called the thoracic duct. Compare this little small vein. That little small vein is pretty much the same size as this thoracic duct. Thoracic duct comes into the left side, but right, it's not right thoracic. That is, cross that off. That should say right lymphatic. There's only one thoracic duct. There are 2 lymphatic ducts, but that's a totally different map. So somebody screwed up that slide. But, you know, it's on the internet, so it's got to be real. Yeah, definitely shouldn't say thoracic there. And that's a more realistic vein pattern from the scalp and the face, and then the external jugular meeting up the internal jugular, dumping into the subclavian veins. All right, everybody. When you zoom out and you look at all of the, you've got your artery vein diagram. Then it looks more like this. Again, where there's an artery, there's 1 or 2 veins running with it. That's the heart. Those are the coronary arteries and the coronary veins. But again, the veins have this nice sinus to dump into, and then the sinus brings blood back to the right atrium. I want this type of, okay. So again, there are your lungs. The blue side are the arteries, the red side are the veins, but then in the body, the red side are the arteries, the blue sides are the veins. And notice that it's a basic mirror image, but then add more veins. Add more veins. Always add more veins. Arteries are under pressure. Arteries can easily get blood to the heart. The veins got to take it back. So they channel into the sinus, it goes back to the heart. Arteries bring blood away from the heart to give nutrients and oxygen-rich blood to the body's tissues. But if it's the right side of the heart, remember, that blood hasn't been oxygenated yet, so it's oxygen-poor blood going to the lungs through arteries strong enough to deal with pressure. And when we look at a picture like this, again, you can see the parallel, but there should always be a little bit more blue in the body than red. All right. Well, everybody, it's time to introduce the lymph vascular. Oh, what a nice picture of artery and vein. It's time to introduce the lymphatics, the lymph vascular side of circulatory. Before I go to the PowerPoints, let me show you what happens when you look at images online. Lymph vascular system. And notice we get away from red and blue. I'll just do it lymphatic. That'll make it anatomy. All right. So we get away from the blue and reds of cardiovascular, and you see green. Those are lymph vessels, and the round things are called lymph nodes. This is an entire chart of the lymphatic system. It's got lymph vessels that start as capillaries in between the tissue spaces. So everywhere you find cardiovascular capillaries, you're going to find lymph capillaries. The lymph vessels eventually bring lymph into lymph nodes. The lymph nodes clean and filter the lymph, and then more lymph vessels, more lymph nodes, more lymph vessels, more lymph nodes. So lymph doesn't just go through one lymph node. It goes through dozens and dozens of lymph nodes, okay? It starts as free tissue space. We have specialized lymphoid tissue in the intestines, in the throat, in the spleen. This is a lymph node with all these lymph vessels, all right? So the lymph is coming into the node, into the node, into the node, into the node, and then it leaves the node. The lymph node has to have blood supply to feed the cells, and then that blood leaves. So it's an organ like anything else, but their job is to clean the lymph. Notice it all green, and it's all over the place. It's in your lungs, it's in your intestines, it's in your body's tissues. Lymph is everywhere. It's maybe everywhere except the brain. But where you find lymph capillaries, you find lymph or cardiovascular capillaries and vice versa. Notice that the spleen is a lymphatic discussion, the thymus gland is a lymphatic discussion, your tonsils are lymphatic discussions, the intestines version of a tonsil called Peyer's patch is lymphatic, bone marrow to some degree is lymphatic. This is a diagram of the lymph vasculature. And I want you to notice something about this diagram. Here he's kind of mint green top right, but everything else is peach. Notice that the greater part of the body is yellow, except for this blue, we'll just say quarter. This quarter of the body is blue, the rest of the body is yellow. That's because all of this yellow lymph drains into the left subclavian. Only this right lymph from this right upper quarter, right head, face, neck, right arm, right chest, and upper abdomen, they drain into the right subclavian, but everything else, because of the legs going to the thoracic duct, because of the arms coming down to the thoracic duct, everything is going to the thoracic duct, which comes into the left subclavian. So that's important for people that learn a technique called lymphatic drainage. If you're trying to promote lymph out of the legs, you're trying to promote that blood flow all the way back to the left subclavian. So lots of diagrams, but notice that when you introduce the lymph, here's a lymph capillary, there's a cardiovascular capillary. The lymph is, if you will, networked or weaved between the capillaries. But the difference, blood in the blood vessels in the capillaries stays in the capillaries and goes to the venous return. The lymph capillaries are open-ended. So they're basically there to pick up the excess fluids and wastes. Whatever doesn't go back into the capillaries gets picked up by the lymph capillaries. So for all intents and purposes, the fluid that becomes lymph starts out as, well, intracellular fluid. Water, mostly, that's inside of your cells. Water in your cells. And then your cells get rid of the water. Now it's extracellular, or if you will, between the cells, known as interstitial fluid. Here is the word right here. Excuse me. Interstitial fluid. About 90%, and there have been some studies that have shown more than 90%. I'm sorry, a little bit less than 90. No, let me say this properly. There have been studies that have shown that the lymphatics may be picking up more than 10%. But if you watch my capillary exchange lecture, I believe that was last Sunday, there was one video where it showed that as the pressure that is oncotic is, pushing blood, as plasma gets pushed out into the free space and joins up with the extracellular tissue fluid, it becomes interstitial fluid, and then some pressure, especially when there's more of cellular waste, pushes back into the capillaries. And so the videos were saying about 90% of what comes out goes back in, leaving about 10% to accumulate. Well, that's where the lymphatics pick up. The lymphatics will remove that excess because now you've got that oncotic pressure pushing through very delicate cell lining of the capillary that's lymphatic. So I want you to look at this top corner where the hand is. These are cells. You've got the capillary. So some plasma is coming out. Capillary plasma, if you will, is leaking out. Intracellular fluid may be leaking out. And so all that fluid eventually goes back into the capillary, except for maybe 10%, a little more, a little less, whatever it actually is. The rest of that gets into this capillary called lymphatic capillary. Now, once that fluid's in the lymphatic capillary, it's no longer called interstitial fluid. It's called lymph. Why they don't call it lymph fluid, I don't know. It's just called lymph. But the lymph is a fluid that's now in a lymph vessel that's going to work its way out of the capillaries into larger lymph vessels, and eventually that lymph vessel is going to bring that lymph into the lymph node. Now, for the better purpose of describing lymph compared to blood, remember blood was red, blood was warm, blood was thick, blood was slightly alkaline. It's a big mixture of a lot of stuff in the plasma, which is 90% water. 55% of blood was plasma, 45% were cells, right? So you got all this blood stuff. So what is lymph composed of? Well, if the plasma that came out and the intracellular waters come out, it's mostly water. But think of it as dirtier water, right? It's not necessarily dirty, but if it was a waste product of cells, if it was plasma with waste in it, it's not the cleanest of fluids. So think of it as dirty, used, spent fluid of the cells that gets picked up by the lymph, and then it's going to go to a lymph node, which is basically a treatment facility for that dirty lymph, trying to clean the lymph up and make it less dirty. Well, if it leaves this lymph node, it's going to go into another lymph node, and through dozens and dozens of lymph nodes on its journey back toward the subclavian veins. By the time that lymph has gone through that many lymph nodes, it's as clean as it's going to be. And once the lymph gets back to the top, all lymphatic flow dumps into a subclavian vein where the lymph becomes plasma. So it's dirty cellular fluid that gets picked up to be called lymph. No red blood cells in it, so it has no quality of red blood cells. It's not delivering oxygen. It's not warming up the body. It's basically the cellular side is absent. with the exception of white blood cells. There's no red blood cells in lymph. In fact, if a red blood cell were to find its way into a lymph node, it would die. The lymph is full of white blood cells called lymphocytes. Oh, go figure. Lymphocytes, white blood cells of the lymph. But they live in the lymph nodes. They don't need to travel in the lymph vessels because they can leave the lymph node through the venous side. They can go into the venous return back to the heart and then use arterial blood to get wherever they need to go, sneak out, fight a fight, sneak back into the blood. And when they find their way back into a lymph node through veins, they leave the veins, go back in the lymph node, and they keep the lymph clean. Lymphocytes are pretty dynamic like that. Look at this version. Instead of green, it's yellow. But it should look just like the artery and vein picture, just a little bit more sparse, I guess. Lots of lymph nodes. All those little yellow things that are nodal-like, those are lymph nodes. And again, they're in chains. Chain of lymph nodes behind the knee, and the groin, and the abdomen, and the chest, lots around the breast, and the armpit, and the neck, and the arm. So when you were a kid, maybe you remember the doctor feeling your neck and going, oh, your glands are swollen. Those were lymph nodes, everybody. Here's lymph coming in, there's lymph coming in, there's lymph coming in, and lymph nodes are the filtration of lymph. Look at how the lymph vessels have valves, just like veins do. Arteries are under pressure. Blood coming right into the lymph node. Blood to feed the lymph node oxygen. But the red blood cells don't leak out. No, they stay in the venous return and go back out. Okay? The red blood cells will come into the capillaries, feed the cells oxygen. The plasma will feed nutrients. These cells survive. And then if the blood needs to be, if the lymphocytes need to mobilize, they'll go into the venous return and use the veins and out. But the lymph is coming in and going through these capsules and being cleaned and cleaned and cleaned. And then most of the lymph goes out a channel and then through another lymph node. I like to think of the lymph node, the very, very first lymph node, as cell block A. And the lymph is the new set of prisoners that are getting ready to go through this prison system. They're coming through cell block A. Look, if they're not, if you will, the dirty material of the lymph isn't addressed, isn't now joining a cellmate, if it happens to make it out of cell block A, well, guess what? They're getting ready to go through cell block B and cell block C. It's very likely that some white blood cell is going to make that bad guy its lifelong jail partner. I was going to say something more rude, but you can imagine what it's like to be in prison. I'm not trying to be insensitive to anybody. I'm just saying, I'm making an analogy that it's not a very hospitable environment for lymph to go through lymph nodes. The job of the lymph nodes is to clean and denature anything in that lymph. So if there happens to be pathogens in the lymph because of the lymphatics picking up some of the pathogens in your tissue, they're going to die in the lymph nodes. If there's things that need to be neutralized, they're going to be neutralized in the lymph nodes. In fact, the lymphatic of the gut, fat molecules are so large and dense that they can't really go into the capillaries of the cardiovascular, so they go into the capillaries of the lymph, and then the lymph nodes break down the fat for your body. So it's a really nice thing. Here are lymph capillaries amongst the cardiovascular capillaries. Look, I can't say it very simply. I can't say it more simply. Wherever you find capillaries of the cardiovascular blood, you're going to find capillaries of the lymphatics. With the one exception, I'm pretty sure that there's no lymphatic capillaries in the brain. You've got your microglia for that. So if you, oops, sorry about that. I knocked over my microphone. If you look between the azygous and hemiazygous veins, they've removed the vena cava in the heart, they removed the aorta, you can see the largest of all lymphatic vessels. That vessel, again, the same size as small to medium veins. The largest of any lymphatic vessel is called the thoracic duct. All of the lymph of the legs, all of the lymph of the left side of the body goes through the thoracic duct to get to the subclavian vein before it becomes returned as plasma. Only the right head and neck, the right arm, and the right chest wall and back, I guess, use the right lymphatic duct to go into the right subclavian. So for drainage purposes, you want to think about the subclavian because the way lymphatic drainage works, okay? Lymphatic flow is not like venous return. Venous return is always toward the heart, right? Always toward the heart. Lymphatic return is not always directionally toward the heart. Lymphatic direction is toward the next chain of lymph nodes, which means that in the abdomen right here, instead of using lymphatic direction toward the heart, you're actually doing lymphatic direction toward the groin. It's almost like you have a big X on the groin, and as long as you're in the circle, you're pushing lymph toward the X. So up the leg to the back of the knee, yes. Up the thigh towards the groin, yes. But once in the groin, it's over the groin. You're not going toward the heart. In the abdomen, lower abdomen and groin, you're going down toward the groin, down toward the groin. In the chest, you might be going toward the armpit, away from the heart with lymphatic drainage to get into the what are called the axillary chain of lymph nodes, and then that. Oh, I keep on hitting my wire, which is knocking over my microphone. I'm so sorry. Let me get my wire out of the way. Okay. So lymphatic drainage is a little different because you want to massage the chest toward the armpit, up toward the armpit, over toward the armpit, over toward the armpit. But the right neck is down toward the heart, left neck down toward the heart. And then once you get to the lower neck, then it's over toward the armpit, over toward the armpit. So it changes. The tonsils are basically lymph nodes that are embedded where part of the surface is pushing into the mucous membrane. And then the other half of it that's deeper acts like any other lymph node. The spleen acts like a mega lymph node. Okay, the spleen is often considered the largest lymphatic organ. The thymus gland, lymphatic because it's what trains the lymphocytes. All lymphocytes, when you're a kid, that are instructed to be born in the marrow, that are eventually going to be called T lymphocytes, their job is to seek out the chemicals created by the thymus gland, go to the thymus gland, basically be trained like elementary school on steroids for those, and then those cells that come out of the thymus gland, they will populate the lymph nodes of your body, and eventually the lymph nodes will be so populated with those that the thymus gland is no longer needed because the lymph nodes are now able to essentially train to be the place of training white blood cells, but not initially. Initially, it's the thymus gland. So the thymus gland is going to degenerate. By the time you're a young adult, there should only be a tuft of fat where the thymus gland once was. But if you look at an infant, a big old thymus gland next to his or her heart, right? So the thymus gland will eventually degenerate. Inside the lining of the intestines, there are what look like tonsils every now and again. No, not much different than your throat, but they're in your intestines. They're called Peyer's patches. I like to call them intestinal tonsils. But anytime you've got mucous membranes and lymph nodes combined, they're collectively known as mucus-associated lymphoid tissues, or MALTs for short. And they're basically just a way to expose the surface of the mucous membrane that has pathogens on it to the lymph node, so the pathogens are drawn into the lymph node where the white blood cells go to town. All right, so let's go to chapter 27. We're going to open up Salvo chapter 27 and look at the lymph vascular as it's discussed. So again, Salvo chapter 27. Salvo chapter 27, it should say lymph vascular system. Lymphatic or lymph vascular system. All right. So again, the really, really big difference, let me go back. The really, really big difference is that cardiovascular is a closed system. Blood vessels get smaller and smaller and smaller in capillaries, and then bigger, bigger, bigger to the heart, okay? Blood cells stay in the vasculature because it's the cardiovascular vessels that are creating the circle. All the heart's doing is creating a push. Please, please, please do not think that the heart is the reason for circulation. No. Circulation means it does a big circle, goes away and comes back. The heart is only pushing it away. The fact that it comes back is because of the blood vessels. The blood vessels accomplish circulation. The heart just drives it. The heart is the pressure, the push. But the cardiovascular vessels are what are circulating. They are what accomplish the circulation. However, Amongst the cardiovascular vessels are lymphatic vessels that are open-ended, like vacuum cleaners sucking up extra fluids, sucking up wastes. It cleans it, and then dumps it back into the cardiovascular system. So it's a side system of vessels, not part of the closed network, but a side system of open vessels that eventually returns everything to the cardiovasculature. Now, immunity is a big part of cardiovascular and lymphavascular, but because of the T lymphocytes being trained in the thymus gland, learning how to fight the fight, there's a greater emphasis of immunity with the lymphavascular discussion than with the cardiovascular discussion. But both have immunity. If you tell me that the cardiovascular doesn't protect the body, I'm going to look at you like that's the craziest thing I've ever heard, because there are absolutely white blood cells in your cardiovascular system, but lymphavascular as well. Protection is a big part of both systems. Lymph is the fluid. Lymphatics or lymph vessels are the vasculatures from the lymph capillaries to the larger lymph vessels to the largest of all, which are the lymphatic ducts. And the largest of any lymphatic duct is called the thoracic duct. But the workhorse of the lymphatic system is the lymph node. The lymph node is the absolute workhorse. Look, the cardiovascular blood gets cleaned by the kidneys, sweat glands, etc., but the lymph is cleaned by lymph nodes. Lymphatics are filtered by lymph nodes, cardiovascular filtered by the kidneys. So when we get to the kidneys in a few weeks, well, actually in a few days, because I think it's a next week discussion, like the next Tuesday discussion, we'll see the urinary system at some point, whether it's Tuesday or Thursday of the following week. Sorry, not this coming week, but the following week. We'll see that the kidneys take the plasma and clean the plasma and then return the plasma. The lymph nodes take the lymph, clean the lymph, and the lymph just keeps going through more and more lymph nodes. So lymphatics are filtered by lymph nodes. And again, they're the absolute workhorse. The lymphatics remove extra fluids in the intestines. They are what absorb the fat, breaking down fat and fat-soluble vitamins, making those small enough to eventually go through the liver, be processed by the liver, and then return to the cardiovascular blood. And the lymph is especially the lymph nodes and the spleen and the thymus gland, very, very important for the white blood cells that we call T lymphocytes. The T of T lymphocytes is for thymus. So lymph fluid started out as fluid inside the cells, as plasma. As they came together as extracellular fluids or interstitial fluids, whatever didn't go back into the capillaries of the cardiovasculature gets sucked up by the lymph. If the lymph vessels are working properly, the lymph capillaries are working properly, you won't look swollen. But if they're not, you will slowly accumulate fluid. And look, I'm an advocate of showing pictures of lymphedema, where the lymphatic vessels are obstructed, where they're not draining lymph like they're supposed to. And when that happens, a person looks like the Stay Puft Marshmallow Man. Now, I'm not just talking about swelling from an injury or an inflammation. I'm talking about swollen, and it's often just one side, one limb, not the whole of the body, not even bilateral. Sometimes, but most of the time, it's one limb. In fact, there's a type of parasite over mostly in developing countries where water is still not well, there's not a lot of water treatment facilities. So a certain type of worm called a filaria worm, very tiny, gets into the water supply and then gets ingested. Well, the filaria worm has a tendency to lay eggs, grow, and now you got a bunch of these filaria worms that travel in vessels in the lymph, especially lymphatics, and then they get stuck, they block the lymphatic. And so a person develops incredibly large limbs known as elephantiasis as a result of the obstructed lymph flow because of the filaria worm. So filaria blockage is, again, not something you see much in the United States, but you can potentially see in a third world or developing country. You're more likely to see following surgery, like breast cancer, or where somebody's had breast cancer and they've had a removal of breast tissue, where the lymphatics of the axillary chain get blocked from scar tissue or whatever, and then the whole of the limb becomes swollen with lymphedema. because of that post-surgical effect upon the lymphatics. So that's another way that we'd see elephantiasis because of that type of, it's known as lymphedema. Again, there's your thoracic duct, the big one. All these lymph nodes, the thymus gland above the heart when you're a kid anyway, the spleen behind the stomach, the tonsils of the throat, the Peyer's patches in the gut. You know, there's your right body drainage through the right subclavian vein. That's the right lymphatic duct. And then there is a left lymphatic duct, but that dumps into the thoracic duct. And then the thoracic duct dumps into the subclavian. So we give all the credit of this entire lower body and the entire left side of the body, left head, neck, left shoulder, left arm, left chest wall, left abdomen, all lower legs, thoracic duct in the left subclavian. That's the drainage model. Even the lining of the stomach, we'll see some lymphatic relationship. But the greatest amount of lymphatic is seen in the small intestines. If we were to zoom in on the small intestines, we'd see what looks like shag carpeting, finger-like projections, and the centerpiece. Imagine if you were to look at my finger and take away the skin and all the tissue, there would be a lymphatic vessel right and through the center. This finger, this finger, this finger, this finger. Now, zoom into microscopic world of the lining of your intestines, especially your small intestine, the part known as the duodenum and the jejunum. These two parts of the small intestine, it looks like millions or billions of these little finger-like projections called villi. And the centerpiece of all villi, everybody, is a lacteal, which is lymphatic. There are capillaries around the lacteal. The small nutrients go into the capillaries. The big stuff and fat goes into the lacteal and then into the lymphatics of the gut. I'll show you that. This is a lymphatic capillary. These are the valves. That's the direction of the lymph. It's called lymph once it's inside the capillary. Lymphatic vessels, again, get bigger and bigger toward the body's center, but the thoracic duct is by far the largest of any lymphatic vessel. That's the one I showed you earlier, that picture. So let's go to shoot. I was looking for something in particular because that's stuff that's related to immunity and inflammation, which is going to be part of our review of the lymphatics. All right, I am looking for something very specific, so I might have to go back to the internet for that. Let's see. Well, I tell you what, let's watch a real brief, like, summary video of the lymphatics, and then we'll call it a day and continue this discussion tomorrow. And then we'll even see cardiovascular pathologies. So let's, what's we got here? One of the images Dr. Dan referenced on veins was from Anatomy Zone. They have vein tutorial. Okay, good. Yeah, use Anatomy Zone again is really good as a video for actually looking at parts. You know, sometimes you have, because they're mostly students that are doing Anatomy Zone. So sometimes you have students from England or from Australia. So there might be slightly different ways of hearing the pronunciation, but you talk about good imagery. Absolutely, Anatomy Zone's got good imagery. So let me go to, oops, wrong one. Oops, that's it. All right, so a real quick video on the lymphatic. What in the world? Lymphatic system. There you go. Or lymphatic or lymphavascular are synonyms. All right, here we go. Basic explanation, right here.
Metro presents a tale of two wireless customers.
I've been a loyal customer since today.
Forever.
Which means I get all the deals.
Absolutely.
In a nutshell, the lymphatic system is a drainage system that removes excess fluid from body tissues and returns it to the bloodstream. It's actually a subsystem of both the circulatory and immune system. The major purpose of the circulatory system is to bring oxygen and nutrients to body tissues and remove wastes. This exchange happens in the smallest blood vessels called the capillaries. Blood plasma containing nutrients moves out of capillaries at the arterial end of capillary beds, while tissue fluid containing wastes reabsorbs back in at the venous end. However, not all of the fluid is drawn back to the bloodstream at this point. About 15% of it is left in the tissues and would cause swelling if accumulated. This is where the lymphatic system comes into play. It picks up the excess fluid and returns it to the circulatory system. Unlike the blood circulatory system, which is a closed loop, the lymphatic system is a one-direction, open-ended network of vessels. Lymphatic vessels begin as lymphatic capillaries made of overlapping endothelial cells. The overlapping flaps function as a one-way valve. When fluid accumulates in the tissue, interstitial pressure increases, pushing the flaps inward, opening the gaps between cells, allowing fluid to flow in. As pressure inside the capillary increases, the endothelial cells are pressed outward, closing the gaps, thus preventing backflow. Unlike blood capillaries, the gaps in lymphatic capillaries are so large that they allow bacteria, immune cells such as macrophages, and other large particles to enter. This makes the lymphatic system a useful way for large particles to reach the bloodstream. It is used, for example, for dietary fat absorption in the intestine. Once inside lymphatic vessels, the recovered fluid is called lymph. Lymph flow is enabled by the same forces that facilitate blood flow in the veins. It goes from lymphatic capillaries to larger and larger lymphatic vessels and eventually drains into the bloodstream via the subclavian veins. On the way, it passes through a number of lymph nodes, which serve as filters, cleansing the fluid before it reaches the bloodstream. Lymph nodes are small bean-shaped structures scattered throughout the lymphatic network. They are most prominent in the areas where the vessels converge. Lymph nodes contain macrophages and dendritic cells that directly swallow up any pathogens, such as bacteria or viruses that may have been taken up from an infected tissue. They also contain lymphocytes, T cells and B cells, which are involved in adaptive immune response, a process that produces activated lymphocytes and antibodies specific to the invading pathogen. These are then carried by the lymph to the bloodstream to be distributed wherever they are needed. The lymphatic system also includes lymphoid organs. Primary lymphoid organs, the thymus and bone marrow, are the sites of lymphocyte production, maturation, and selection. Selection is the process in which lymphocytes learn to distinguish between self and non-self, so they can recognize and destroy pathogens without attacking the body's own cells. Mature lymphocytes then leave the primary for the secondary lymphoid organs, the lymph nodes, spleen, and lymphoid nodules, where they encounter pathogens and become activated. Thank you for watching. If you like our videos, be sure to check out our new Patreon page. Patreon is a simple way for you to contribute to our production and get great rewards in return. Join us to...
All right, so the question asks about a study guide. Let me stop the share first and then I'll open the chat. So the question is Dr. Dan a study guide or any diagrams available to prepare for? Yeah, I have it all. I'll send it with today's link so that you have it ahead of time. But yeah, you'll see it's pretty nice. And you'll have that to go on. So all I have really to do is kind of expand a little bit upon that lymph vascular discussion, talk a little bit about immunity, and then included in the study guide are the video links that I'll recommend for the 15 pathologies that are cardiovascular and lymph vascular. And that way, you can look at those videos as part of your studying, and then I'll just, as I introduce the pathology, talk a little bit about it and contraindications, all that good stuff. So yeah, look for that study guide to be attached to today's lecture, and I'll see you tomorrow at 3 p.m. Okay, everybody have a great rest of your day. Enjoy, and see you tomorrow. Bye-bye.